How's it going, guys? We have a medium difficulty question for Gastro, steps 1 and 2. 24-year-old dude, he has nephrolithiasis on a background of Crohn's disease, and we're just asking the most likely mechanism for his acute presentation, which is the nephrolithiasis. Choice A, excessive intake, vitamin D and calcium. Wrong fucking answer. So obviously hypervitaminosis D could cause hypercalcemia, and in theory, okay, that could lead to urolithiasis, but it's not what we have here. What you need to know is that for USMLE hypervitamin D, highest yield etiology is sarcoidosis. Okay, lengthy discussion. Obviously, you got the non-caseating granulomas, usually in the lungs, and the macrophages are going to be secreting 1-alpha hydroxylase. You get increased active 125D3, goes to the small bowel, increases calcium absorption, hypervitaminosis D, causing hypercalcemia, and that'll suppress your endogenous PTH due to increased negative feedback. Choice A, wrong fucking answer. Choice B, hyperparathyroidism primary. Wrong fucking answer. So parathyroid adenoma, okay, it could be diffuse foregland hyperplasia, it could be associated with MEN1, MEN2A, just see it in isolation. So just for USMLE, the past level stuff is that you would have high calcium, low phosphate. All right, I mean, I don't really know what to tell you. It's that's just past level endocrine stuff. You could have increased ALP activity as well. You need to know the mechanism for the PTH binding, obviously, to osteoblasts, and then the osteoblasts are going to produce ALP. So increased osteoblast activity causes increased ALP, all right? And then the osteoblast expresses rank L, binds to rank receptor on the osteoclast, and that's how we get the bone resorption. Choice B, wrong fucking answer. Choice C, secondary hyperparathyroidism. Wrong fucking answer. And USMLE, this is going to refer to renal failure. Okay, so what does the kidney normally do with calcium? It reabsorbs it in the late DCT. So if the kidney's fucked up, we can't do that. Hypocalcemia, in addition, it's going to have 1-alpha hydroxylase activity in the PCT under the action of PTH. Well, if we can't do that, we can't make 125D3, can't get the small bowel absorption of calcium, hypocalcemia, and then that low calcium decreased negative feedback at the calcium sensing receptors, parathyroid glands, PTH goes up to compensate. Choice C, wrong fucking answer. Choice D, actually for those of you in kindergarten, okay, step 1 stuff real quick, I'll just explicate that you need to know for choice C, you got down arrow for calcium, up arrow for phosphate. Okay, so it's the opposite of primary. We said primary hyperparathyroidism, high calcium, low phosphate. Well, secondary, it's the opposite, low calcium, high phosphate. There's some annoying stuff involved. Vitamin D deficiency, if not due to renal failure, down arrow calcium, down arrow phosphate. But if you have vitamin D deficiency in the setting of renal failure, the renal failure wins, and you're always going to have an up arrow for phosphate because you can't get rid of phosphate at the kidney. Okay, I talk a lot about that stuff in my high yield arrows, high yield endocrine PDFs. As I already said, wrong fucking answer. Choice D, increased absorption oxalate, correct answer. Okay, so you're going to have malabsorption in the setting of Crohn's disease, not just the terminal ileum where you can get B12 deficiency, because that's the classic location, mouth to anus for Crohn, but terminal ileitis. Okay, so B12 deficiency, but you can also get fat soluble vitamin malabsorption. So ADEK, all dogs eat kittens, fat soluble vitamins, but increased fat in the lumen of the small bowel, secondary to malabsorption, increased fat within the lumen to bind to calcium, chelation effect. So if that's occurring, there's less calcium available to bind oxalate, which means more oxalate can be absorbed. Okay, so if that's confusing, all I want you to know is just you get increased absorption of oxalate in the setting of Crohn, and that can make its way to the kidney where you can get calcium oxalate urolithiasis. Okay, whether it's a kidney stone nephrolithiasis or a urotero uroterolithiasis. They ask it on the USMLE. Okay. Final answer, increased uric acid production. Wrong fucking answer. So, I mean, it could be something such as Lesch-Nyhan syndrome, X-linked recessive condition. You get a kid who's got orange, red crystals in the diapers, self-mutilation, deficiency of HGPRT. Wrong fucking answer. You know the deal. Until you make more content, it'll be so scrunching. Appreciate your time. That's it.